Welcome to the LDN radio show, brought to you by the LDN Research Trust. I'm your host, Linda Elseygood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose Naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. This show is sponsored by Mark Drugs, who specialise in the custom compounding of medications, assuring that the client gets the proper prescriptions for their unique needs and conditions. They work with practitioners, integrating knowledge and treatment of experts to create comprehensive health plans. Visit markdrugs.com or call Roselle 630 529 3400 or Deerfield 847 419 9898. Today I'm joined by Dr. Dr Schatz, who's an MD from Tucson in Arizona. Thank you for joining me today, Dr. Schatz.
Oh, well, thank you for having me. I appreciate it.
Well, first of all, can we find out about you? Could you tell us about yourself, please?
Absolutely. Well, I am a medical doctor working in Tucson, Arizona. I'm currently a third year and chief resident of our residency program at the University of Arizona for family medicine. I was born in Pittsburgh, Pennsylvania, and I did my undergrad training in Ohio at a small college called Hiram College that no one has ever heard of. Before I did the rest of my medical training at Stony Brook University in Long Island, New York. And I decided to move down to Tucson, Arizona for my residency training because of the world-renowned University of Arizona Center for Integrative Medicine, which I'm looking forward to being one of the residential fellows this year, this upcoming year, beginning in July of this year, to further pursue training in integrative medicine.
Mm-hmm. So, in your career, where did you hear about LDN?
So initially, it's kind of a funny story. In medical school in Long Island, we had a patient who came in who had an ulcerative colitis or Crohn's flare. I don't recall which, but he had an inflammatory bowel disease flare up. And he had to be admitted to the hospital for IV fluids and for monitoring and everything. He was very sick at the time, and I remember talking to him, and, I was very early in my training in my third year of medical school, and they just first sort of bring you out of the classroom and into the hospital. And so I didn't know much about medicine in general, let alone integrative medicine or Crohn's or low-dose Naltrexone. And so I was talking to the patient about what he's tried before and all the medications that have failed. And he looked at me and he said, "But guess what? In 2 weeks, I'm going to meet a doctor in New York City, and he's going to start me on low-dose Naltrexone." And I remember that vividly, but I also remember that I had absolutely no time to look into it at all. Mm-hmm. And I sort of filed that away because a lot of people, especially in the world of integrative medicine, you hear about a lot of different treatments. Some have a lot of evidence and some have very little, and you really don't know what to make of it on first pass. So of course I didn't spend much time looking into it. I had a million other things I was trying to learn at the time. But I filed it away, and over the past few years and months, really, I've started to hear more and more and more about low-dose Naltrexone. And so I have a few colleagues here in Tucson who use low-dose Naltrexone very commonly. And so I had brushed into it, talking to some of their patients and hearing about what they were taking it for and how it was working with them. And I got extremely interested just hearing the anecdotal evidence of how people's pain is getting better, how people are off of their thyroid medications or their immunosuppressive medications for their autoimmune diseases. I mean, lots of good word of mouth. Mm-hmm. And I got intrigued. And that's really what led me in the past, few years, months, really diving into the research and then using it with my patients with success.
Okay, so what conditions are you mainly prescribing LDN for?
I'd have to say probably first and foremost, far and away, I use it for pain, all sorts of different pain indications. So fibromyalgia or chronic regional pain syndrome, complex regional pain syndrome, formerly known as reflex sympathetic dystrophy. Also just chronic low back pain has had some improvement, but also other illnesses, autoimmune diseases, Crohn's that I mentioned earlier, thyroid issues as part of a comprehensive and anti-inflammatory autoimmune treatment program. And that's sort of about probably everybody, but, adding more and new patients by the day.
So when you prescribe LDN for chronic pain, if a patient comes to you and they're already on an opiate painkiller, how do you go about weaning them off and starting LDN, or do you do both? What do you do?
I mean, that's an absolutely great question, and that's the first question that I usually hear, because a lot of these patients are on chronic opiates, and in America today, we've actually turned this, the opiate crisis. We are really not doing our patients much justice by handing these medications out like they used to hand them out. So patients do come to me on these medications, and they really are, we demonize them in some sense, but they really are, a lifeline for a lot of people. So you can see how reluctant a lot of people with chronic pain are to stop these opiate medications, because they just simply can't function without them normally. And so there's a lot that goes into mostly sort of putting a plan together and having a patient know that I'm there for them, but they have to really wrap their minds around stopping those medications, which is the first step, and it's very difficult. So once we've done that and we have a plan together, my plan typically consists of slowly tapering their opiates. So if they're on a combination of long-acting and short-acting, we taper the long-acting first, because once that's out of the system and they can control their pain with the short-acting we can stop quicker and start the LDN shortly after. So I usually, my goal is to get the long-acting off totally, keep the short-acting on, and then they can, about 24 to 48 hours after their last dose of the short-acting, I usually say, if it's a Sunday night, take your last Percocet on a Sunday night, and then either Monday night, depending on how you are, or Tuesday night, take their first dose of LDN. And when somebody's weaning off of an opiate, it just depends, what the indication is and how much you're going to start, whether you're going to start really at 1.5 or 3 or even 4.5, or even lower, like micro doses in the beginning. That all depends, but I typically try to get it within that 24 to 48 hour window after, so that people know that they're not going to be left out to dry for longer than, a day or two without what they can really see as a life-preserving medication. Mm-hmm. So as you can tell, there's a lot of nuances. It's very complex.
So what experience do these patients have coming off the opioids before they start LDN?
Well, it's difficult, and it varies. Some people really have no problems at all. I've seen people who kind of show up and they say, yeah, and we discussed a plan and we picked a date and say the date's like a month from the last visit, and then they'll tell me, yeah, it was like a week after I saw you. I just kind of stopped it and started at LDN. Things went well. I mean, and so that I kind of attribute to more of the psychological aspect is, once you realize that maybe this isn't something that you need to live, speaking about the opiate medications, then you're a little less reluctant to give it up. So that's been one response that I've seen that always makes me happy. I can tell you that. Sometimes, though, it's difficult, and sometimes you have to go back to the drawing board and say, okay, well, remember that keep your Percocet with you. So if you, if you start the LDN and it doesn't go the way that you're expecting it to or you thought it would, then take a Percocet and start back and let's wait and let's try it again another day. And that's happened sometimes. And the beauty about LDN, the really creative genius is that it's such a low dose that you can actually still take your opiates and you're not going to go into a withdrawal, and you'll still get the effects of the opiates. You just won't really get the effect from the endorphin rebound or any of the really the anti-inflammatory effects. But you can still take it plus or minus with small doses of opiate medications. It's not something that's going to be life-threatening. It's not going to throw people straight into withdrawal and really hurt them, especially if they're already properly weaned off of them in the first place. So,
yeah. So the outcomes, and I know everybody's different. Everybody's pain levels are different pain conditions. But what would you say you would expect to see as an outcome? I mean, how long would you think it would take before the patient noticed some improvement?
And that's a great question as well. That's what I always hear from patients is, how long am I going to have to wait until my pain is better or this improves my condition? And from what I've seen and from what I've read, it's extremely variable as well. Mm-hmm. Some people come in and say, especially when you start at a higher dose, they have that initial endorphin rebound and they tell you that this is the first time I felt alive in years. I feel like myself again, and they feel like they've been given something back. And so that's, of course, that's what this is all about. That instant gratification really, as a professional, helps me to continue what I'm doing, but that's not always the case. And I'd say that is almost more the exception. Typically, it takes patients, anywhere from 2 to 4 to 6 weeks. There's a beautiful case study that I read recently on a 35-year-old guy who had low back pain, and he had been tried on opiates and anti-inflammatories and antidepressants of like 3 different categories, and anti-epileptics and trigger point injections and steroid injections. No improvement of his pain. Once they got him on the 4 milligrams of low-dose naltrexone, 2 weeks later, 30% reduction in pain. By 6 weeks, he's completely back to work. And that's an interesting case study, too, because they stopped the medication at 10 weeks and then followed him up 6 months after starting it when he was totally off of it for, almost 4 months. And he was still having just minimal pain and was still completely, fully functional back at work. Wow. And that's something that I totally see. I mean, that's the power of LDN, and I think that's what patients see and they hear. And this is a medication that's very much consumer driven. People come to me asking for it rather than most doctors knowing of it and using it as a treatment, which is something that I know will change with time and with data and with evidence. But
well, I should think your patients.
I
should think your patients are very grateful to have you as a prescriber.
Well, I appreciate that. I think I'm just here to provide, health any way I can. Medicine is, in my mind, medicine is a street fight, right? Like whatever I need to do to get that person healthy, if I have to pick up a bat or a lead pipe, whatever we can use, whatever kind of treatment therapies we can use to make people feel better and to get back to living their lives, I'm going to do it. So
that's amazing.
That's what led me to LDN.
And have any of your patients reported any negative side effects other than maybe, vivid dreams, sleep disturbance? That's one of the more common things is a little bit of sleep disturbance, and I like the way that you state it there because it's really not insomnia. It's not a sleep problem. It's just a change in their sleep habits, and people, that can be remedied quite easily by making sure that we optimize our sleep hygiene prior to initiation of LDN, and also by just making sure that, we take the proper steps when we're initiating it to not really start too high of a dose or,
if we do start at what we think is an appropriate dose and have some issues, we sort of drop it down and begin that taper upwards.
Mm-hmm. And you mentioned...
But as far as...
Sorry.
That's right.
Carry on.
I was just going to say, you mentioned other side effects, and I didn't touch on, but one more thing I wanted to mention as a side effect, which I find extremely interesting, is and it's not an unfavorable side effect. It's that patients tell me that their issues with binging, so binge eating or binging and purging, really decrease when they start the LDN, which I find fascinating, and kind of don't surprise me, knowing the mechanism with opioid growth factor and opioid growth factor receptor and beta endorphins, and having that endorphin surge when you're binging. That's sort of the reason why people binge eat, is for the endorphins to quell some sort of inner pain. And so having your opioids inside your body, your beta endorphins at a higher level, which can actually satisfy those cravings, and you don't need to binge, it's something that is fascinating to me, and I just feel like is another possible indication for using low-dose naltrexone in patients that binge. I haven't done it yet. I haven't found a patient that's binging and given them low-dose naltrexone just for it, but I'm going to think about it.
Just can't think of his name now. Andre Levy.
I'm sorry, I interrupted.
It's all right. Andre Levy-Wiesberg, he uses LDN in his weight loss clinic, and he finds it works very well. Dr. Mike Schuckman, who's a psychiatrist, he uses it for different addictions as well. It's quite amazing, all beautiful. The different things that LDN can be used for.
And that's so true. And actually, that reminds me, because there is a formulation of a weight loss drug that's FDA approved in the United States for weight loss, and that's a combination of an antidepressant and low-dose naltrexone. It's called Contrave bupropion, and the dose in this formulation in Contrave is actually 8 milligrams of naltrexone, which is, as we know, is a little on the higher side. But that's also something that people have been using for weight loss, at least across the pond. But I'm interested to learn that there's other practitioners. That's very exciting to me. I'm going to look those two names up.
Well, I'm getting older, and probably people as they get older don't drink as much alcohol. I don't know. It depends if you're an alcoholic, I guess, or what they call now alcohol use disorder. I used to go out for a meal and maybe have, say, 2 glasses of wine. I was never a big drinker. But now, after I've drank 1 glass, I really don't want any more. I just really just don't want it. And if the glass is a big glass, I probably wouldn't even drink all of it. Not because of any, it doesn't make me feel nauseous or anything. I just feel I'd rather have water than drinking the alcohol. Strange, isn't it? It's not because I am limiting myself, because I don't go out often to drink, and I don't drink at home. But I really just feel I don't want it. I just don't want it. So that's
totally. That's amazing. Yeah, I mean, it really is a wonderful medication. It really. So the new applications, I just keep hearing, are almost endless.
Exactly. Do you prescribe capsules or liquid initially?
So we have a local compounding pharmacy. Little shout out to Reed's Pharmacy, amazing, in Tucson, Arizona. They're absolutely wonderful. We really appreciate their help and their service. And they provide a compounded form, basically to any dose that we would like. They can put it together for us. So the most economical, though, I've learned for patients, which of course is always a factor. We have a very high number of the population in our clinic, a high percentage of with Medicare, which is our sort of our government's form of sort of, I guess, the closest thing we have to socialized healthcare, which we're working on. But so that's for our indigent population. So the most economical is the 3 milligram for a 90-day supply that they can do quite easily for us, which we appreciate. But mostly capsules, yeah.
Mm-hmm. Okay. What do you do when you start people off if you want to give them less than 3 milligram?
So yeah, typically then I'll have reads put us together either a 1.5 or a 1, and the 1.5 is nice because they can get 90 capsules there quite economically, and then of course that's an easy way to double it to 3, and then to add another 1.5 to get to that max dose there of 4.5. Mm-hmm. But that's typically our procedure.
Okay. So when a patient first comes to see you, do you always prescribe LDN if it's appropriate? Or do you wait a while and use other medications or treatments first?
Well, it's a really good question. Typically, so I have a little trouble answering because I typically see 2 different styles of patient visits, basically. So I have my primary care clinic where I see, it's still in the 15-minute medical model where we see people and we work on whatever their issue is, prevention as well as acute care. And so in those patients, in that patient population, they don't know much about low-dose naltrexone, and it seems slightly foreign to them. And honestly, they somewhat, that's mostly our Medicare population, so they somewhat frown upon having to spend their hard-earned money on medications that they have to get from a compounded pharmacy rather than something that will be freely available at another pharmacy. So in those situations, I recommend it, and I talk to them, and I do my best to educate and to give someone the tools to continue their education at home and see if they, come back and want to pursue and go down the path of LDN, which I really see as more of not just a holistic, but it's really, it has a different mechanism, right? You're actually treating a mechanism with low-dose naltrexone. You're not just covering up a symptom. Mm-hmm. So then in my other practice, on the other hand, I have an integrative medicine practice that is budding and growing every day. And so in those patients, those are the patients that come to me either requesting LDN or having heard of it in some specific way. And if I see that there's an indication for low-dose naltrexone, I'll just discuss it because it doesn't treat symptoms. Like I said, it treats mechanisms, but it still doesn't, get to the cause, right? So if someone comes to me with hypothyroidism and they do have antibodies for Hashimoto's, it's like, well, why do they have Hashimoto's in the first place? Is it that they have dysbiosis and they're eating gluten and these things are leaking through their intestinal walls with their permeability being just terribly poor? And that's really the cause. So I can treat their autoimmunity with low-dose naltrexone, but I use it as part of a protocol that it actually addresses the causes as well. And my goal, my picture for all my patients is to have them well and functioning at their highest level off of any sort of crutches, including medications and supplements. So it's really just doing lifestyle changes, living their life in a way that will promote health and disease. And that includes LDN. As much as I love it and as much as I use it, I want people to be able to not have to live with it as a crutch for their entire lives.
Mm-hmm. Wonderful. Do you give telephone consultations, Skype consultations, or are they all face-to-face?
It's a great question because part of this upcoming fellowship is that I'll be changing my practice quite a bit. So currently I do not do any Skype or phone consultations. That may be a part of my upcoming practice, but I have some hesitation. So I'm a little reticent because I just really cherish that face-to-face interaction with patients. And I think that's a big part of the healing process, is to have someone that and sort of give you that physical presence. That healing presence is something that I cherish. And so if the desire is there, if people really come to me seeking that, then absolutely, I'll do it. But we'll see what the future holds, I guess.
So if people want to come and see you and have an appointment for a face-to-face consultation, where do they go to? Have you got a website?
I do, yes. So I can be found at georgeschatz.com, GeorgeScha, as in apple, T as in Tom, Z as in zebra.com. And that's the easiest, quickest way to get in touch directly with me and my team, and we can get you scheduled for appointments starting pretty soon. We're booking out a couple months, but pretty soon, yeah.
Okay. So we know how they're going to contact you, what they're going to do. So let's hope that the patients around, I suppose you'd cover all of Arizona, would you? Or only certain parts?
Well, I'm really just based out of, my physical practice is based out of Tucson, Arizona, which is sort of in the southeast corner. Mm-hmm. So, people are welcome to come on down from Phoenix, and people do, frequently, but I'm totally licensed in the board of Arizona, so I can see anyone in Tucson, anyone who comes to me from any state can always be seen. Okay,
fantastic. Well, thank you very much for having been our guest today. It's been very educational. Thank you.
Oh, well, thank you. I really appreciate the opportunity.
This show is sponsored by Mark Drugs, who specialise in the custom compounding of medications, assuring that the client gets the proper prescriptions for their unique needs and conditions. They work with practitioners, integrating knowledge and treatment of experts to create comprehensive health plans. Visit markdrugs.com or call Roselle 630-529-3400 or Deerfield 847-419-9898. Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.